Hi, this is your Houston chiropractor, Dr. Gregory Johnson. We have Mark in here with us this morning, and this is Mark's very first chiropractic treatment ever, right?
Yes, sir.
And you found this on YouTube, right?
Yes, sir.
And you've been watching me and Dr. Ian, you said?
Yes, sir. For a long time.
For a long time. So you consider yourself a crack addict?
Yes, sir, I do.
Okay, good. Well, Mark's going to be part of a very special video today because I'm going to get highly technical on what I do here and how the body functions and the nervous system functions and the spine functions and how the Johnson chiropractic technique influences the neurophysiological state of the human body. So we're going to evaluate Mark's posture first, which is a three-dimensional space orientation on the x-axis, the y-axis, and the z-axis. And a lot of you have always wondered why I have the patient close their eyes, and that is so that it takes out his visual three-dimensional space orientation sensory input coming in from his eyes. So close your eyes for me there, Mark. Now flex your head forward and backwards for me, and then back to neutral. Now see, with his eyes closed, proprioception starts taking place. Proprioception is an afferent sensory nerve supply that goes from the joints and or the tendons through his spinal cord up into the brain, and specifically the cerebellum, the hindbrain, which controls 80% of all posture and kinetic functions of the human body. So you can see from looking at his posture, his head is way forward on the z-axis, his ears dropping all the way out here in front of his clavicle, and it should be back here over his shoulders. That's why his hands are out in front of him like this. And you can also see that his head is translated off to the right on the x-axis. And it's also tilted right on the z-axis. So there's a rotation negative on the z-axis up in the cervical spine, which is made up of 7 vertebrae from the atlas, C1, C2 called the axis, all the way down through C7, which is the base of his cervical spine. And then next is the thoracic spine, which is made up of 12 vertebrae. And then down in the lumbar spine, which is made up of 5 vertebrae normally. And then the pelvic structure, which is made up of the sacrum, which is a middle triangular shaped bone. And get the spine here so I can demonstrate this a little better for you. Come back here for just a second. So, in looking at his biomechanics with his eyes closed, it takes out his visual proprioceptive neurological input to the brain, which allows me to see his true biomechanical configuration of his spine in gravitational weight-bearing analysis. Now, in this, it's really important to see too, you can see his thoracic or lumbar spine and pelvis has translated to the right on the x-axis. He has no room over here versus on the left side he's got quite a bit of room over here. So he's translated forward and right up in the cervical spine region and translated to the right down in the lumbosacral spine and pelvic region. So I've already done his orthopedic neurological examination, but I'm going to go ahead and lay him down and go over a few scientific and technical aspects of the spine and nervous systems. Lay you on your tummy. So if I were to overlay this plastic replica of the spine, now this is not one of our patients that ripped their spine out doing the ring dinger. This is a plastic replica teaching spine. There are actually 33 segments total in the spine. They call them 33 vertebral levels. There are 24 freely movable vertebrae throughout the cervical through the lumbar spine. There are 5 segments in the sacrum. They're at birth, they're separated, and then they ossify and form a solid bone in the sacrum. And then there are 3 individual segments in the coccygeal region, which again ossifies as we grow older to become 1 segment. and there are 31 pairs of spinal nerves. The spinal nerves, as you can see, come out between the vertebrae directly off of the spinal cord to supply every organ, muscle, tissue, and cell in Mark's body, and all the way down into the lumbosacral spine, the sacroiliac region, and even the coccygeal region. Now these spinal nerves connect the spinal cord to specific areas in the spine or in the body. In the cervical spine, you've got the cervical plexus, which is the plexus of nerves that come out between C1 and C5. And then you have the cervical brachial plexus, which comes out between C5 through T1. Those nerves come out into the shoulders, arms, and hands and fingers. And Mark has, in his history, told me that he has had some cervical brachial plexus problems, which radiate out into primarily his left arm and the hand, getting numbness and tingling and pain out to your shoulders. Right, Mark?
Sir.
Now, these nerve fibers are, the central nervous system is the brain and the spinal cord. The peripheral nervous system is all these spinal nerves that go out into the periphery of his body, his organs, muscles, tissues, and cells, and limbs. You have an autonomic nervous system made up of the parasympathetic nervous system and then the sympathetic nervous system. The sympathetic nervous system goes from T1 down to L2 here, and it makes things go kind of in hyperdrive. So if you get like fight or flight symptomology with increased heart rate or spasm in your esophagus or your stomach, that's usually a hypersympathetic response. The parasympathetics are exactly opposite of the sympathetics, and they cause a calming effect of the organ, muscle, tissue, or cell that they're affecting. So the autonomic nervous system made up of the sympathetic and the parasympathetic nervous system work together to create a state of what we call homeostasis in the body, which is a normal function of the internal environment of the body. That's homeostasis. Homeostasis actually equals health. If you have a normal function of the autonomic nervous system, of the parasympathetics and the sympathetics being in balance so that your organs, muscles, tissues, and cells are equally calmed down from the sympathetic and the parasympathetic nervous system, your body remains in good health and maintains a normal function. However, if you get a misalignment, you might want to get closer up on this, misalignment of these vertebrae, let's say in his mid-thoracic spine, you can see the nerve openings here called the intervertebral foramina. They get pinched off and pinch those nerves that go out to supply, for instance, T5 supplies the stomach and the digestive tract. You get down in the lumbosacral plexus, these nerves come out down into the pelvis and all the way down into the legs and the feet. And Mark's already had L5-S1 surgery in his lumbar spine down here for a herniated disc a few years ago. And the nerves that come out, the spinal cord came out of this guy here. It's not looking good for him. Okay, we'll stuff that back in there. There we go. Okay, so now he's had a reoccurrence of his pain coming out of his lumbosacral spine that radiates down into his legs and his feet. And that's called lumbosacral radiculopathy or sciatica. So, but also during the examination process, when I evaluated him, I found that he had a rotation of the SI joints and a misalignment of the sacrum on the right side, which he had a right sacral deviation test. He had more problem lifting his right leg up when I pushed down on his sacrum like this than he did his left leg, which indicates that the sacrum has posteriorly rotated on the right side. That affects the sacroiliac joint. This big bone over here is called the ilium. Bilaterally called the ilii, plural. So when you have a sacroiliac, sacrum, ilium, sacroiliac joint subluxation, you can affect nerves out of the lumbosacral plexus that go down into the legs and the lower legs and the feet and get numbness and tingling sensations, which are sensory in nature. Now you've got two types of neurological connections, and this is the science behind the Johnson chiropractic technique. Every single joint in his spine and pelvis is a synovial joint surrounded by a synovial capsular ligament. That synovial capsular ligament has afferent neurological nerve endings that attach to the Golgi tendon, which is the proprioceptive neurological component that feeds information from that particular joint position up through the spinal cord into the cerebellum to let him know, or let his body know actually, that he has a pain and problem down here at L5. He really doesn't have pain at L5. He senses the pain in his brain as a result of the afferent postganglionic neurological information that travels up his spinal cord through the lateral spinal thalamic tract into his cerebellum and then into the cerebrum, into the forebrain. So, putting the spine back over here on its model holder for just a moment. See, his legs are even here, which is a good start, but then when I bring his legs up, his left leg gets a little shorter and that tightens up a little bit in your low back and pelvis, doesn't it, Mark?
Yes, sir.
Yep. So see, this is the sacral deviation test. Lift your right leg up. Okay, now do the same thing on your left side. And you can see that it was more difficult to get his right leg up as high as he did his left leg, and it probably was a little more uncomfortable on the right side, correct?
Yes, sir, it was.
So what I'm going to do with the Johnson adjustment here, which is a combination of Thompson technique, BioPhysics, and pure still-wagging technique that I have combined together to adjust his sacrum first on the right side. There we go, that's a good one. Then his right SI joint, which is internally rotated, so I'm rotating this on the x-axis, adjusting him also in the y-axis and z-axis, and then I'm going to hit his sacrum in the center, and then his left sacroiliac joint here. And now I'm going to move up into his lumbar spine and adjust L5 straight P to A. And some of these be a little sore at first, Mark, because they've been out for a while. There's L4. There's L3. L2. All the way up to L1. Now, I haven't done this before, but I'm going to show you today pre and post check. So we're going to push down on his sacrum again. Go ahead and lift your right leg up. Look at the difference in how that leg went higher. Did you feel the difference in that, Mark?
Oh, yes, sir.
Now do the left one. Did they feel more even that time?
A little bit.
Okay, you still felt a little more on the right?
Yes, sir.
So I'm going to hit his right sacrum again. Now, a lot of you think I'm doing the same adjustment on every patient that walks in the door. I'm using the same techniques, but I use different pressures and angles. Go ahead and lift that right leg up again. Now that's much better.
Oh, yeah.
Do the same thing here. Did that feel more symmetrical?
Oh, yes, sir.
Okay. So let's recheck your leg length. You're still even. Let's see if you stay even. Yes, you do. I bet you that felt smoother than that first one did.
Yes, sir, it did.
Good. So I'm going to go ahead and bring you over here on this table over here and adjust your lower thoracics, which you have a lot of tension right in that thoracolumbar spine region. And if you think I'm making all these words up and using all these technical words to confuse you, go ahead and look them up on Google Scholar. Now, I want you to let your spine kind of relax in there. So I'm getting a contact right here at T12. There we go. That was a deep one. That's it. Yes, sir. Now come back over here on this table again. Watch that wire. You felt those deep, didn't you?
Yes, I did. Felt good.
That's a Gonstead knee chest adjustment. Okay, just relax your spine now. There we go. Now, every time I adjust his synovial joints, I create an afferent neurological signal that goes up through the cord into the cerebellum and then back down to those particular joints that reorient his cerebellar function, brain function, with his paraspinal joint function and his motor joint articulations, which is one vertebra above attaching to the vertebra below. Each has 4 joints. So I'm going to tighten this up. You're going to feel your head popping up a little bit now. Now the joints in the 7 vertebrae in the cervical spine are called facet joints. Slide down this way a little bit. These facet joints are like pillars holding the head, the bowling ball, up on top of the spine. And that's the purpose of the cervical spine, is to hold the head up over the shoulders. His head was forward, so he has subluxation or misalignment in his facet joints throughout his cervical spine. Now in his lower cervical spine, the subluxations that he has there is affecting the cervical brachial plexus, which is why he has pain out into his shoulders, arms, and hands. So I'm going to adjust the curve back forward in his cervical spine. I don't know if you noticed on the spine before, in the lateral view of the spine, there's supposed to be a forward curve in the cervical spine called a lordosis in those 7 cervical vertebrae. In the thoracic spine, there's a backwards curve called a kyphosis. In the lumbar spine, there's a forward curve in here, again called a lordosis, the same as the cervical spine. And then you get down into the pelvis and the sacrum and you see another kyphosis. And then down in the sacrum, there's another lordosis that takes place, but that's so minimal that most people don't really notice that one too much. So there's really 3 basic primary curves in the spine. The cervical spine is a lordosis, thoracic spine is a kyphosis, and then the lumbar spine again is a lordosis. And I guess we should include the pelvis, which has a kyphosis again. So when I adjust his joints, I'm moving these facet joints back into a better biomechanical relationship with the adjacent facet, which stimulates the mechanoreceptor in the capsular joint ligament, creates an afferent neurological, proprioceptive neurological impulse that goes up this cord into the brain, back down to that joint, and then realigns the joint back into a better biomechanical relationship with the adjacent vertebra joint. So I'm adjusting C through C7, and then I'm going to get down on T1 here. Good. Excellent. Let's turn you on your back now. Now on this one, I'm contacting his zygomatic process here, and I'm bringing his whole head back up and over his shoulders because his head's forward, so I'm trying to get his head back up over his shoulders. And this also creates an afferent proprioceptive neurological response from these joints up into his brain, back down to these joints, recalibrating those. So I'm going to have you put both arms straight out to the sides now. Now, not only are the joints of the spine and pelvis synovial joints, his shoulder joints are synovial joints, AC joints, glenohumeral joints, these costosternal joints and costoclavicular joints are also synovial joints and have afferent neurological receptors in them that communicate through the spinal cord back up to the brain. So I'm actually recalibrating and doing a master reset, if you will, of his entire nervous system. You can relax your hands on your tummy now, please, Mark. Let this relax in my hand here. There you go. Now you should have felt that from your knee all the way up to your pelvis.
Oh, yes, sir.
The knee's a synovial joint, the hip's a synovial joint, and his SI joints are synovial, as well as the lumbosacral joints are synovial, which have afferent neurological receptors in them that communicate information back into the spinal cord up to the brain, and then efferent neurological impulses come back down and recommunicate with those joints to reset those joints. Let's sit you face this way. So, his shoulder is a synovial joint. I just moved that synovial joint, which sent afferent neurological impulses into the cerebellum, and the cerebellum sent back down efferent neurological information down into his glenohumeral joint, resetting and recalibrating that joint alignment. This is his left glenohumeral joint. Perfect. Felt both of those, didn't you?
Yes, sir, I did. Oh.
Now see, he feels those things because of the proprioceptive neurological communication from the afferent nerve fibers that are in the capsular ligament that tells him where his body is in relationship to spatial orientation. You may have heard of the famous fighter from Greece known as Achilles, and then the Achilles heel, which is where one of the, there we go, good, okay. Let's come over here. Who was it that shot Achilles' heel? What was that guy's name?
Oh, I'm not sure.
Oh, it's one of the princes of, slide up a little bit. Okay. This is going to feel tight in here, Mark. It's supposed to. Okay, so he has 24 freely movable vertebrae from between his occiput and his sacrum. I am doing a master reset on the y-axis, taking off weight-bearing compressive joint stress in the facets and zygapophyseal joints, which also have afferent proprioceptive neurological information that goes from the joint to the brain, from the brain back down to the joints, reorienting them and recalibrating them in space. So I wrap this wet towel around his occiput and his mandible. Do a straight horizontal lift on the table here. It's actually vertical in the y-axis. Now you should have felt that all the way down to your sacrum.
Yes, sir.
All the way down your spine.
Oh, yeah.
This reflex is a prime example of how these neurological reflexes work. When I contact his patellar tendon in a reflex, that immediately goes up into the spinal cord. Efferent impulses come back down and tell the tendon to react, which it does. And that is how the reflex works. It's a reflex arc that's directly from the tendon through the spinal cord back down to the tendon. Now on the palmar diversified rotary brake, I'm contacting him down at the C6, C7 vertebral levels, adjusting the synovial joints in his lower cervical spine that sends afferent proprioceptive neurological information into his cerebellum and then back down through the cord to these joints, recalibrating these joints' alignment, and then also taking off pressure on those spinal nerves that come off of the spinal cord that's causing him to have left arm and hand pain and numbness, or right arm and hand pain and numbness, whichever the case may be. Okay, let's get up sideways and stand over here in front of the mirror. Now, a lot of you have been asking over the years, what is this instrument? This is a high velocity, when it's turned on, high velocity, low amplitude, Atlas specific adjusting instrument. You can see it push my finger very fast, that's high velocity, but it's not pushing it very deep. That's the amplitude. It's just like a sound wave. The amplitude, if it's a large amplitude, that's a big wave. If it's a small amplitude, that's a small wave. So it's high speed, but low amplitude. And I'm going to adjust his atlas, which affects the tractus solitarius and the nucleus intermedius here in the brainstem, sends messages up into his cerebellum. The cerebellum is responsible for balance, coordination, and all kinesthetic movement throughout his body. So I'm going to put him in a mirror image configuration. I'm going to adjust his atlas on the x-axis, which will send afferent neurological proprioceptive information into his hindbrain, the cerebellum, which will send back down through the spinal cord efferent impulses, which reorient his biomechanics in his spine and pelvis. Now you see you got a little room over here now.
Sir.
You didn't have that before. So let's pull both shoulders up and back. See, so I'm putting him in a mirror image of his current biomechanical configuration. Now his head is forward and a little right, so we bring it straight back on the z-axis, translate it left on the x-axis, tilt it left on the z-axis, and then externally rotate it negatively on the x-axis. You're going to feel a little tap right there. You're going to feel another little tap right there. Now relax. Okay, now flex your head forward and backwards again. Did that feel any smoother to you than the previous ones?
Yes, sir, it did.
Take a look in the mirror right now. See how your head's straighter than it was before?
Yeah, a lot straighter.
And look, you got space now on both sides down here. So what I just did with this Johnson three-dimensional XYZ axis adjusting technique is I affected the mechanoreceptors that sent afferent impulses into his brain, that reconnected back down through his spinal cord, out the intervertebral foramina, through the spinal nerves, which changed his biomechanics in standing weight-bearing gravity. And we did that with his eyes closed. You notice it takes out his visual three-dimensional orientation in space. So walk around and tell us how you feel after that first adjustment. This is
Real good.
Mark's very first adjustment ever.
Oh, man.
Was it what you expected after
Yes.
watching our videos?
Yes, sir, it was. It was fantastic. It was
Do you
good.
feel better than when you walked in the door?
Way better. I feel more straighter.
Did you understand what I was talking about when I was
Yes, sir,
explaining
Yes, sir, it did.
the technical aspect of
Yes,
what
sir,
we're
it did.
doing? Does it make sense to you?
Yes, sir, it does.
Good.
I
Well, thank
appreciate
you
it.
for sharing your experience with everyone.
Thank you. Appreciate it.
This is your Houston chiropractor, Dr. Gregory Johnson, coming to you from Advanced Chiropractic Relief, where we practice hardcore chiropractic adjustments, pure and simple, every single day, all day. We'll see y'all soon.